Hey everybody. Just gonna take a second to get everything fired up here. So we're gonna give it a couple more minutes just to make sure. I know we had a lot of RSVPs, so just give it a minute or two before we get going. Can everybody hear me okay and see the title slide?
Yes, we can.
Awesome. All right, well, I'm gonna start. And first, thank everybody for joining this inaugural session of our clinician education series. Today, I'll be talking about the science of cannabinoids and pain management. We'll talk a bit about mechanisms, clinical evidence, and practical integration. Should be about 45 minutes or so. We'll leave a little time for Q&A. And I'll just be talking to the science. And then I will pass the mic over at the end to Ivory Zworsky to talk a little bit about the product side of things and the Charlotte's Web offerings. So we will kick it off. Just quickly, a disclaimer out of the gate that this presentation is intended for informational purposes only and doesn't constitute medical or legal advice. All clinical decisions should involve physician judgment and shared decision making with the beneficiary. Implementations must comply with all applicable CMS model terms, federal, state, and local laws, and that all products, when we get to the ivories, the part of this, are not FDA approved to diagnose, treat, cure, or prevent any diseases. Just a legal disclaimer, I guess, out of the gate. So just a minute about me. My name's Marcel Bon-Miller. Welcome. I'm the Chief Scientific Officer at Charlotte's Web. But I'm also a cannabinoid researcher, and I've been doing cannabinoid research for about 22 or so years. I got my bachelor's degree in psychology and PhD in clinical psychology at the University of Vermont. I did my postdoc at Stanford. I am, in addition to my job at Charlotte's Web, I also have a academic appointment at the University of Virginia. My research career has really been, it spanned all sorts of academic and medical center settings, from my time at the Department of Veterans Affairs, as well as at the University of Pennsylvania, where I was for quite some time. About 9 or 10 years ago or so, I moved into industry, starting out at Zynerba Pharmaceuticals, developing transdermal CBD for pharmaceutical development. I then went to Canopy Growth Corporation, where I oversaw global R&D. And then I've been at Charlotte's Web for about 3 years, a little over 3 years. I've got a little over 200 publications, about 175 of which are specific to cannabis and cannabinoids, some sort of outside of that. And I've really focused a lot on comorbidities. So really trying to understand how cannabinoids interact with pain, anxiety, HIV, PTSD, and sleep disorders. Just wanted to give you this as a little bit of background, just so you had a sense of who I am and why I'm here. And again, I'm very much interested in conveying what we know and what we don't know on the literature. And I'm going to give you a pretty level view of the empirical literature at this point on cannabinoids and pain. If you have any questions, we'll hold them to the end. But just really appreciate everybody being here. This is one of many that we'll be doing on a monthly basis, and I'll announce the next one at the end of this talk. But yeah, excited to have you. So in terms of learning objectives, I think these were included. I'm going to talk a bit about endocannabinoid pharmacology for pain, talk a little bit about receptors, CB1 receptors, CB2 receptors, TRP receptors, PPAR gamma. I'm going to talk then about THC and CBD as the evidence anchors, really where most of the work has happened on cannabinoids and pain, and what we know with chronic pain, neuropathic pain, musculoskeletal pain, et cetera. And we'll talk a little bit about the topical literature too. Then I'm going to talk a bit about minor cannabinoids. So outside of THC and CBD, what do we know about other cannabinoids that are emerging in this space? I'll also talk a bit about route of administration, how that impacts onset, duration, et cetera, and how that's important. And then kind of conclude with some practical integration across disciplines. So really thinking about chiropractic audiences, physical therapy audiences, massage, acupuncturist, primary care, depending on where you're coming from. What are the take homes, or what do you really need to help integrate this within your practice? So starting off on the pharmacology for pain. So really there's 5 receptor and channel targets that are important for pain. First, we have CB1 and CB2. This is cannabinoid receptor 1 and cannabinoid receptor 2. These are the classical cannabinoid receptors. CB1 being primarily in the CNS, CB2 being predominantly peripheral in the nervous system and immune systems. Then we also have TRPV1, which is a capsaicin receptor, and it's relevant for CBD action as well as for some topical formulations. So we're going to talk a little bit about that. PPAR gamma is the nuclear receptor that gives cannabinoids anti-inflammatory effects. NAV 1.8, that's a newer story. Maybe, I don't know how many of you, have gotten that deep into the pain side, but it's a peripheral sodium channel with recent human proof of concept for analgesia. So kind of an interesting one. And again, an important mechanism within the pain space. So then it's important also to know the endogenous ligands and tone associated with the endocannabinoid system in pain. So really, the endocannabinoid system is made up of receptors, as you saw on the left, CB1 and CB2, and then endogenous ligands. So anandamide and 2-AG being the most studied of those. Anandamide is a partial agonist of CB1, and it's also a TRP ligand, and it's degraded by Fa, and 2-AG, which is a full agonist of both CB1 and CB2 receptors, and it's degraded by MAG lipase. So really, endocannabinoid tone can be altered in chronic pain states, and phytocannabinoids and terpenes modify signaling simultaneously, which is a mechanistic basis for the entourage effect. And you probably heard a bit about the entourage effect, but really think about the endocannabinoid system is something that really needs to be in homeostasis. And when it knocks out of homeostasis because of reduced levels of, for example, anandamide and 2-AG or increased receptor availability of CB1 and CB2, we need to kind of get it back into balance. And there's many different ways of doing that. Bringing in exogenous cannabinoids, CBD, THC, CBG, et cetera, is one way to kind of rebalance it. Think about cannabinoids as like a supplement that you're bringing in to help out anandamide, 2-AG, for example, in their job regulating your system. A little technical, but I wanted to make sure for those that are interested in the mechanism side of things that we covered that so that you understood what the important pieces of this. So this is a kind of a receptor level map, if you will, for cannabinoids that we're going to discuss in this, and a terpene as well. THC, so delta-9 tetrahydrocannabinol. So this is right the piece of cannabis that is associated with some intoxication at high levels. This is when you think of cannabis and you think of getting high in cannabis. That's THC that's driving that effect. But THC is also found right in low levels within hemp, and non-intoxicating. You really need above, you start to even get any signal of any sort of euphoric effect or whatever, 5 milligrams and up. Below that, you don't see much from an intoxication standpoint with THC. THC is a partial agonist for CB1 receptor, partial agonist for CB2. And like I say here, it does produce some intoxication, particularly at above 5 milligrams or so. You can start to see some intoxication. CBD, cannabidiol, right? This is the primary cannabinoid found within hemp. This is a negative allosteric modulator at CB1, very weak at CB2. It's not huge in terms of how I know a lot of people have talked about CBD as in the endocannabinoid system. CBD doesn't interact much with CB1 and CB2. Most of its mechanisms are outside of that. So it's an agonist at TRPV1. It's an activator at PPAR gamma. It's an inhibitor at NaV 1.8. And it's not intoxicating, right? If you just look at pure CBD, you don't see any intoxication up to thousands of milligrams, not associated with it. CBG, cannabigerol, this is another one that we'll talk a little bit about. It has some activity in the endocannabinoid system. It's a weak partial agonist at CB1, partial agonist at CB2, and then it has these interactions with TRP, PPAR, and NaV 1.8 as well. Also not intoxicating. Lots of studies have shown no intoxication associated with CBG. CBN, cannabinol, you might have heard of this in the sleep literature, and a little bit in the pain literature as well. This is a weak partial agonist at CB1, a partial agonist at CB2, inhibits 1.8, and also not intoxicating. Really, there's been a number of different studies that have looked at CBN and many routes up to pretty high doses and haven't really seen any intoxication from CBN. Interestingly, CBN is a degradant of THC. So when you have THC and it sits out in the sun, it is exposed to oxygen, it's exposed to heat, it'll not so slowly, depending on the conditions, degrade and become CBN. So that's where CBN comes from. CBN is actually not produced by the plant. It is a result of degradation of THC that's produced by the plant. We'll talk a little bit about CBC, cannabichromene, which is a partial agonist at CB2 and has some indirect activity with TRP. Also not intoxicating. And then beta-caryophyllene. Beta-caryophyllene is a terpene. It's found in pepper, among other things, but also in hemp. It's terpenes being responsible for the smell and taste that you experience when if you think of the smell of cannabis or the smell of different hemp varieties and the actual plant level, or the taste that you get when you try a tincture or something like that. It might have like a hempy taste. Some of that is made up. Beta-caryophyllene is one of those terpenes that produces that. And terpenes are not specific to the cannabis plant. Like I said, beta-caryophyllene is found in pepper, and there are other terpenes that we won't touch on today, like linalool, eucalyptol, et cetera, that are found in many other plants. important for the conversation. And as we talk about isolates versus full spectrum, when we talk about isolates, we're talking about specific studies of just THC or just CBD. When we're talking about full spectrum, it's really about the combination of all of these different cannabinoids that are found in full spectrum products, and how they can impact outcomes. So I'm going to talk now a little bit about THC and CBD as sort of the evidence anchors, really what it is that, really kind of been holding the torch, if you will, from the evidence perspective on pain and cannabinoids at this point. So really, and sort of the headline here is that THC and combinations of THC and CBD have the deepest human evidence base of any cannabinoid intervention for pain. National Academies came out with a report in 2017 that concluded, and this was sort of a big National Academies report, looking at all of the evidence for cannabinoids and a number of different outcomes, pain included. So it was pain and epilepsy and a number of different others. And they said that there was substantial evidence for cannabinoids in chronic pain in adults. There's some data on nabiximols, which is a combination of, it's sort of a one-to-one combination of CBD and THC. And the literature that nabiximols and the development of that kind of one-to-one combination of THC and CBD is very robust. It's an oral mucosal spray. This is a FDA-approved medication. Sativex would be another word for it. It's not FDA-approved yet in the US, but it is approved in Europe and a number of other countries. Showed modest but pretty, strong, modest but real, I'd say, significant effect sizes in multiple sclerosis related neuropathic pain and cancer pain. So important context for the bodywork of the evidence is that there's been decades of human RCT data, particularly in cancer pain, multiple sclerosis spasticity related pain, and chemotherapy-induced neuropathic. On the other hand, evidence is mixed with refractory neuropathic pain. There have been multiple recent RCTs in patients failing standard treatment that have shown no clear benefit of THC, CBD, or a combination of the two over placebo. Adverse events across these pain studies: dizziness, sedation, some cognitive effects, dry mouth, more common a little bit with THC, but most of the adverse effects are pretty mild to moderate and often dose related. So higher up, you have more adverse effects. So really just thinking about the takeaway right now is that there's a decent amount of evidence for THC and the combination of THC and CBD for analgesic effects. But the indication matters, right? It's not for every type of pain. It's only for, or there's certain types of pain that do better than others. So talking a little bit about a large meta-analysis that was done by Wang and colleagues in 2021 and in BMJ, British Medical Journal. It's the most comprehensive recent meta-analysis of medical cannabis and cannabinoids in chronic pain. They looked at, so meta-analysis, right, looking at all of the studies that have been done and not just doing a review of those studies, but really pulling in, looking at the data, looking at the stats, and kind of going through with a microscope to really understand the degree to which cannabinoids can be helpful in this case. There were 32 randomized trials with 5,174 adult patients, and really non-inhaled, right? And we're talking about this, non-inhaled medical cannabis produces about, and this is so primarily THC, a 10% absolute increase in the proportion of patients achieving the minimally important difference in pain relief, with a range of about 5 to 15% or so. So meaning, yeah, a decent chunk of people achieve minimally important difference or clinically significant, we'll say, reductions in pain. There's small improvements that were also shown in physical functioning, in sleep quality. and adverse events, again, were mild to moderate. And so what it's showing is that there is small but important evidence for THC and the combination of THC and CBD for pain, functioning, and sleep. And so the important point is really matching what cannabinoids we're talking about with, like I said, the specific pain indications that are most amenable to change from cannabinoids. So here, this was another study. This was Bilbao and Spanegal in 2022 in BMC Medicine. And they took a pharmacological specific approach to a systematic review, parsing RCT literature, so randomized controlled trial literature, by which specific cannabinoids were used rather than lumping them all together. So instead of just looking like at the last one on medical cannabis does this, right? It's like, well, let's drill down and specifically understand which is THC specific, which is THC plus CBD, and CBD alone. And so in this study for chronic pain, you'll see kind of broke down where most of it is. So findings for chronic pain, dronabinol, so this is essentially a synthetic THC, had moderate certainty of evidence for small to moderate effect size. Nabiximols, so again, the sort of one-to-one combination of CBD and THC, had moderate certainty of evidence for a similar effect on chronic pain. We also saw an effect for MS-related spasticity, so spasticity associated with multiple sclerosis, and sleep. Both CBD and THC as a combination seem to really help with sleep at a pretty moderate level of evidence. Now, if you take CBD as an isolate, so, right, we've talked about THC alone, we've talked about the combination of CBD and THC with the nabiximols data, and then if you look at CBD alone, there is very strong evidence for epilepsy, right? And we now have an approved drug, Epidiolex, that is a pure CBD, botanically derived, but pure CBD. It's not a full spectrum that helps with, and it's been approved for Dravet and Lennox-Gastaut syndromes. So we know that the evidence is high for that. But when you look at chronic pain and CBD isolate, there wasn't a significant effect. And so this really highlights the importance of a couple things. One, having THC in the formulation is pretty critical for pain, whether that's THC alone or THC in combination with CBD that could be full spec all the way up to one-to-one nabiximols. Isolated CBD really is helpful in the literature for epilepsy. In what was reviewed here, CBD's pain evidence, like I said, was by itself is not that strong. But where you start to see it is when it's combined with THC in, for example, full spectrum formulations. And CBD also in the background can enhance the efficacy and tolerability of things like THC by modulating the drivers of them. So it might not hit pain as an endpoint, but it might help reduce inflammation, which then could reduce pain, if that makes sense. And topical CBD is the sort of exception here, which we'll get to in another slide. So here's more. I know I'm giving you lots of data, but it's important to understand how much has actually been done on cannabinoids and pain. It's a lot. This is a 2024 systematic review in pain management nursing from Muhammad and colleagues, showing that 42 to 66% of patients reported pain reductions across 15 different studies. Now, this included open label studies, observational data, and RCTs. And I think it's important to really take into account more than just your traditional RCTs, especially with cannabinoids, right? Because with cannabinoids and spending tons of money and going through these long clinical trials is important and can help understand nuance and understand difference from placebo and things like that. But the reality is lots of people are using cannabinoids for pain, right? And there's tons of people that are out of this isn't, RCTs, particularly, if they're looked at as gating, that's really sort of the traditional pharma model, right? Where you need to document evidence. You have a new chemical entity, you have a new drug. You need to understand how it works. You need to document its evidence in terms of efficacy in sort of a very systematic way as you lead up towards approval. And that's great, and that's a great point for development of drugs. Need to do it. Need to understand how much better it is than placebo, what the treatment effect is, et cetera. That said, that's assuming that this thing isn't in the market already. In this case, we have the opportunity of doing observational studies, real world evidence, lots of different and open label studies to really understand there's already a lot of people out there. What are they reporting? And what are they using? And and there's so much of that data now that we really need to weigh that in addition to those RCTs. So, anyhow, my digression a little bit on that, but as is the case, right, real world data are a bit messier, and so the signal can vary a bit by population and product. 3 of the 15 studies showed no significant improvement. So the signal is there, but it's not universal again across all types of pain. And that's again what hopefully this will be one of the big takeaways here. Next slide. So topical. This is what I have here. This 2020 study is the most cited topical CBD RCT, and it was done in peripheral neuropathy. It was small. It was 29 patients, but it was very well designed. And when they saw statistically significant reductions in intense pain, sharp pain, cold sensations, and itchy sensations. And so it's important it's important to understand the demographics here too. The mean age of this sample was 68. They didn't see any adverse events. So this is, when we think about sort of the broader population, there are lots of places, and we see this particularly in an older adult population, where CBD can be really helpful topically. So it has as a route of administration, right? So we talked about, and again, we're talking about CBD alone here, not the CBD plus THC or THC. This was just CBD. If you look at across routes of administration, right, we talked before about how little evidence there is for CBD alone and pain when taken orally. When taken topically, this is one of the examples of some of the strongest data for CBD is topically. And so, for chiropractors, physical therapists, massage therapists, acupuncturists, seeing patients with peripheral neuropathy or musculoskeletal pain, topical CBD is a form factor where the science is most defensible and could be really helpful as an adjunct to manual work. And you'll see this a little bit as we go through the practical integration. Minor cannabinoids. So now we're going to get beyond CBD and THC and talk a little bit about the others. CBN is one. So again, most studied for sleep. But on the left, you'll see that there's been some work preclinically showing that both CBD and CBN in that study, in this first one, Wong and Cairns, acted as a peripheral analgesic. In a rodent model, Schwartz tested 5 minor cannabinoids for CIPN, and CBN was actually the one that stood out. And in the next study, CBN also through that NaV 1.8 channel that we we're talking about before appears to have a good mechanistic case for pain. But when we move into human studies, there are none yet published placebo-controlled human trials of CBN for pain. What we do know is that CBN helps with sleep, and that's where the strongest evidence right now is kind of lies. This is one of my studies actually that's highlighted on the top end. This is an RCT that we published a few years ago, highlighting that CBN at 20 milligrams reduced number of awakenings and overall sleep disturbance relative to placebo. This was a full double-blind RCT across 7 nights of exposure. why does this matter for pain? And the reason I kind of want to highlight it is that sleep disruption, right? These are not everything, as you probably know, right, does not occur in isolation. And a lot of things can impact each other, right? And sleep and pain are pretty tightly wound. And so sleep disruption, we know from the literature, can amplify pain perception, and pain disrupts sleep. So for chronic pain populations, comorbidity is the rule, right? Not the exception. And so the fact that we have a cannabinoid that can help with sleep, it's something that should be considered, right, for the broader pain population as well. CBG. So here, this has the deepest preclinical pain literature, actually. There's been a number of studies that have looked at CBG across, like you see here, a number of different studies across a number of routes of administration, and all of them are positive across many different pain models with a number of different mechanisms. Um, for example, that the bottom study there, I'm not going to attempt to pronounce that name, identified CBG as the most potent NaV 1.8 inhibitor of the three minor cannabinoids that were tested. Um, that said, they're orally with certain types of inflammation. Orally, CBG has not been, this was one study by Elise Wirtz. This was over at Johns Hopkins. This is a recent study that didn't show it for specific types of pain. But like I said, for CBG alone, despite the volume of preclinical work, we haven't quite gotten to the place of a placebo-controlled human trial for CBG. Hopefully that will come soon. I did a study a few years back looking at a combination of CBD and CBG for pain, but with CBG alone, and that was for delayed onset muscle soreness. For CBG alone, we're not there yet. And again, the hard part is that, as you can see, all the types of pain, all the different cannabinoids, it takes a while to catch up on the science side. CBC, and so CBC has the thinnest literature, I would say, of the three minor cannabinoids, CBN, CBG, CBC being the thinnest of them at this point. Mechanistically, there's some evidence there, but standalone evidence in modern pain models is pretty limited. I'd say where CBC matters most is in the combination of other cannabinoids. There was a study that on the right you can see here, Svensson et al. In 2025 is the cleanest recent demonstration, I'd say, where subtherapeutic CBD combined with levels of CBG, CBC, and CBDV produced an entourage analgesic effect in another pain model. And I think that's really important when you think about CBC. The framing is that the case for CBC monotherapy is thin, but CBC as a contributor to a full spectrum extract is a bit more defensible. And actually, when you look at hemp-derived extracts, you see that you look at the profile, look at a certificate of analysis of all the different cannabinoids that are in a full spectrum extract. It goes CBD is the most, and then most of the time CBC is actually the second most abundant cannabinoid that you see in a full spectrum extract, and then comes THC. So important to understand that role within the context of a full spec and where CBC can play a role. And then there's a study by OBX. This was a group in North Carolina that helped funded this study, and this is the largest cannabinoid pain trial that's been run, single trial. So it was 1,629 participants, and 44.8% of participants reported clinically meaningful pain improvement in the study. They looked at CBC at 20 milligrams, added to CBD at 40 milligrams, improved pain relief in a moderate pain subgroup after about 2 weeks or a little over 2 weeks. But there's some methodology issues with this study that are important to take into account. One of them is there was no placebo arm. That's okay, right? But just important to note. And that all of the arms in this study, there were a whole bunch of different arms, 6 different arms in this study, contained 40 milligrams of CBD. So the 44.8% figure that we're talking about is with a within arm pre-post improvement, not necessarily right a comparison to placebo. Also importantly to note, and I'm going to give a few caveats on this study. The other one is this has not been published yet. This came out as a press release, and it talked about these data that I'm presenting here within the context of that. But as of now, that I haven't seen the published study of this. So again, a cautionary note about the data, and until something is fully through peer review, I don't want to spend too much time or put too much weight on it. But interesting to note, and I thought it was worth covering nonetheless. Route of administration. So it matters. And I can walk through kind of each row here. Oral is the slowest onset and longest duration. Bioavailability orally is low and highly variable. It's good for sustained chronic pain coverage. And it's also good for precise dosing, right? If you wanted a specific amount for a specific pain indication, oral is nice in that way. Sublingual is faster and somewhat more bioavailable because it bypasses first pass metabolism. Sublingual being you could use a tincture, but you're keeping it in your mouth and you're allowing it to absorb some oromucosally before it gets swallowed. It can be the best route for titration, where the patient wants to control some over time. Topical, it's about local effect, right? With minimal systemic exposure, sorry. And there's a recent study by Hopkins, a group at Johns Hopkins, including Ryan Vandry and a number of others, that looked at topical products and whether they had just local versus systemic absorption. And really the headline was there was a little bit of systemic absorption in some formulations, but generally speaking, they should be thought about as local. And so important to understand that topical is definitely a real effect and a good effect, but minimally systemic. It's good for localized musculoskeletal and peripheral neuropathic pain. Transdermal patches are a different animal entirely. Those have sustained systemic delivery. That said, be careful about products that are out there claiming to have transdermal activity. It's rare to have real transdermal activity outside of what I've seen in the pharmaceutical development space. You get minimal a little bit in, again, some products, but not across the board. And inhaled is the fastest onset, but not really relevant here, right? Not really relevant to over-the-counter products, and does carry some pulmonary risk. We're still, there's still some debate about that. Of course, very quick onset, quick peak effects, but not very relevant here. So route choice should match pain pattern is what I would take home from this. Acute breakthrough pain warrants faster onset. Chronic background pain wants sustained coverage. And the other thing I'd say, and there are caveats to all of this, but with oral, where we do say slow onset, slower to peak, there are technologies in oral products that have come out that can speed up onset because of, there's some people that want that systemic, nice, management of chronic indications, but know that waiting 2 hours, right, up to 2 hours or whatever it is for onset is not going to work in a breakthrough pain population or whatever. So there have been a number of companies that have introduced fast-acting technology to gummies, not a number of, some companies that have put fast-acting technology in their gummies to speed up that onset. and improve bioavailability. And so it's important as you go through gummies is primarily where you see them, maybe some in some capsules. Important to understand whether that technology exists because that will shift the conversation a bit in terms of expectation. So going to, I guess, towards the end of this now, and then I'm going to pass it over to Ivory, talk a little bit about entourage dosing and practical integration. So here, what we know is that full spectrum. Want to talk a little bit about sort of the importance of distinction too. And I'm trying to throw isolate under the bus. I think isolate has its place, particularly for individuals that are hesitant about using THC in any form, even a small amount. But it has its place. And I would say that, and for some underlying pieces like inflammation, it might not help with pain at the outset, right? Like we've talked about a bit in this study. It may help with some of the underlying processes that can then be implicated in symptoms of pain. But it's tough. CBD isolate, first of all, it forms what's called a U-shaped dose response curve. What that means essentially is that there's a spot. You can work your way up in titrating, start low and go slow, which we'll mention here at the end. Work your way up to an ideal dose. And then if you keep going, it actually becomes less effective. So that's one piece is that dosing, it's not linear, which makes it a little bit harder. And it means that there's a narrow therapeutic window where more isn't always better. The other problem is that with CBD isolate, you need quite high doses to be able to get pain effects. If we're talking about 20 milligrams of CBD, 50 milligrams of CBD, it's not going to cut it. Typically, when you see effects, I don't think hardly anyone with CBD isolate, very few studies, very few clinical trials, I'll say, have documented any benefits at below 150 milligrams per day. And most of the studies are looking at 300 to 900 milligrams per day orally to see effects of CBD isolate, again, depending on indication. And for epilepsy, it can be up into the thousands of milligrams per day. So that is another piece of that. And with that high amount of dosing comes increased risk for some liver complication, but more importantly, the real risk is drug-drug interactions because there are common pathways by which CBD is metabolized that also co-occur with lots of other drugs. And at low levels, it's less of an issue. When you're at very high levels, it can be a problem. Something to watch out for at the very least. So full spectrum is where I would point individuals, right? Because again, THC is a big part of the story in combination with CBD, as well as those minor cannabinoids, CBC, for example, CBG, CBN, which all commonly occur within the context of full spectrum formulations. Terpenes as well, right? Terpenes are included in full spectrum formulations. And they have a big role to play in the modulation and anti-inflammatory effects of those cannabinoids. So they're often more practical. You don't have to go as high from a dose perspective at all. Much, much, much lower doses. We see, for anxiety effects, even 30 milligrams a day. There's a recent study, using a full spectrum extract that showed 30 milligrams a day in reducing anxiety. You don't, again, full CBD isolate studies, you're at 150 plus per day to see anxiety effects. So that entourage effect is definitely real and one that plays itself out in these full spectrum products with these different indications. So dosing implications, I'll say kind of briefly, start low, go slow. Begin with lowest labeled serving size and work your way up slowly. Match route to indication, right? Topical for muscular, localized, and peripheral neuropathic pain, oral and sublingual for sustained or systemic pain. Acute breakthrough pain is the weakest indication for most OTC hemp products. Schedule dosing on a fixed interval, for example, morning and evening. Don't chase symptoms, really come at it systematically. Predictable steady state exposure outperforms PRN use for chronic pain. So really coming into like, how do we build up, particularly orally, but also topically, how do you build up and have a very constant amount of cannabinoids that are delivered to help really nip it in the bud, if you will, and reassess to understand, dosing and effects. If there wasn't any meaningful improvement at the upper end of the labeled dose range by 4 to 6 weeks, reconsider whether this is the right thing. CBD, cannabinoids in general don't work for everybody. They work for a lot of people. And again, you see that in the effect sizes of, in the significance of the studies that I presented, but not everybody. So, note that. There's also drug interaction watch points. I talked a little bit about this before. Most of it's related to CBD, and it's mostly related to CBD isolate, where you're dealing with much higher amounts. But what I would say is the biggest one I would say is warfarin or any other prescription blood thinners are the biggest watch out. Generally speaking, CBD increases the amounts of those active drugs within your system, and so it can lead to potential bleeding events. And so it's, particularly in older adult populations. And again, this is about oral use. If you're using topically, this isn't an issue. This is about oral use, and particularly at higher doses of CBD. Just important to watch out for. And what I would say is counsel patients to discuss their use with their prescribing physician. If you aren't a prescribing physician, if you're a chiropractor and PT and massage, acupuncture, et cetera, just an important one to watch out for. And then if you look across disciplines, right? So for chiropractics, I'd say topical CBD for localized pain, inner treatment recovery. It can be a nice adjunct to manual care. For physical therapy, topical is great for manual work, and oral for sustained chronic pain that limits exercise tolerance. For massage therapy, topical integration, counseling patients on expectations, common sense application considerations. For acupuncture, I think that there's a real mechanistic bridge through ascending pain modulation. Cannabinoids and acupuncture both engage that system. And for primary care, I'd say patient selection, drug interactions, and opioid sparing I held out. We'll have a separate talk on opioid sparing. It's a hot topic within this, but I figured it sort of it deserved its own talk. But every discipline in the room, right, has a defensible case, I would say, for cannabinoid integration with topical CBD as a nice starting point, and then oral full spectrum, ideally, right, again, with THC as a good place to hit those systemic approaches. So again, quick takeaways. I'm going to open it up for maybe a Q&A really quickly, and then I'm going to pass to Ivory, hopefully, for a second or two. So key takeaways here, THC and CBD are really the evidence anchors. Topical CBD has the cleanest case for adjunctive use. CBG, CBC, and CBN are mechanistically promising, but not much has been done on the human trial space at this point. Full spectrum versus CBD isolate matters a lot clinically from a dose perspective and from a safety perspective, and practical integration and matching product to route to patient is really the approach that one needs to take. I'll stop here for some Q&A. I've got references. I'm guessing these will be shared out. So there are references at the end that I talked about for each of the peer-reviewed studies. Feel free to drop questions in the chat. Let's see if there is stuff in the chat. Any questions? Otherwise, well, let me kick it to Ivory. Ivory, since I've just got it in presenter mode, so I'm just going to say also, I keep cutting Ivory off. Sorry, Ivory. So appreciate you coming. Next session is next month in July. We'll be sending that out. We're going to talk about cannabinoids and sleep. Really a good one. Should be a really fun one where you'll hear some more of that CBN story that I started talking about. So look for that invite. And now handing the torch over, and I guess I'll advance the slides, Ivory, because I don't know how to.
Okay.
Okay. Yeah.
Yeah, I'll just let you know when to go to the next slide. So, quick introduction, everybody. Hi, my name's Ivory Zavorsky. Similar to Marcel, I have my doctorate in clinical psychology with a background in behavioral pharmacology and cannabinoid science. I've been in the industry, mostly in research and development, for the past 6 years. So today, I just wanted to give you basically like a little bonus webinar to talk about our CBD clinic products and specifically talk about the products that apply to pain and all of the research that Marcel has been chatting about today. So if we can go to the next slide. Awesome. So this is an overview of our full CBD clinic oral products. So we're not going to talk about all of them today, but I just wanted to let you know this is what the CBD clinic lineup looks like for our oral products. So we have 4 different gummies, and then we have full spectrum soft gels, a full spectrum oil, and an isolate oil. We can go to the next slide, Marcel. Awesome. So first we'll talk about our Relieve and Ease gummy. So this actually combines 4 different cannabinoids that Marcel touched upon earlier. So we have 15 milligrams each of CBD, CBC, CBG, and then we have 2.5 milligrams of THC. And one thing that's important to note for this formulation is all of these cannabinoids are in a cyclodextrin-based encapsulation. What that means, without getting overly technical, is it allows these cannabinoids to bypass first metabolism. So what you end up seeing is a faster onset and higher bioavailability. So this is super great in comparison to a traditional gummy that takes a while to kick in. You're seeing results a lot faster. You're going to feel those effects a lot faster. So this has precision dosing of those 3 cannabinoids at 15 milligrams. And then we've got THC at the 2.5 milligrams. So low dose THC, the CBD, CBC, and CBG in combination, which we've seen a lot of promising signal in the research for. So this is super helpful for reducing exercise-related inflammation and easing those kind of everyday aches and pains that patients can present with. Serving size is 1 gummy, which is also really nice. So you don't have to be taking a bunch of this throughout the day. 1 gummy, and you're getting these targeted effects. Next slide, Marcel. And then next, I want to talk briefly about our 2 different sleep gummies that we have in this lineup, just to touch upon that pain and sleep relation that Marcel was talking about earlier. So, our first that we'll talk about are our Stay Asleep Plus gummies. These gummies have 30 milligrams of CBN, which has been a dose that has been examined in the research. So, in one study, 20 milligrams was shown to be effective, and another study, 25 to 50 milligrams has been shown to be effective. So, we're right in that sweet spot there with 30 milligrams of CBN, showing support for helping people to stay asleep throughout the night. So, what that really looks like is less frequent nighttime awakenings. And in studies looking at like adverse effects, we're not seeing that next day grogginess that people can sometimes experience when they're taking different sleep aids. So, again, 1 gummy per serving size here. It's going to help you stay asleep throughout the night. Important thing to call out here, there is no THC in this formulation. It is just that CBN isolate. And next slide. Awesome. And then we have our quality sleep gummy. So this has that 30 milligrams of CBN that we just talked about for stay asleep, paired with fast acting 2.5 milligrams of THC. So this product does have THC in it, and we consider this to be like a dual action formulation. So we have that fast acting THC in that special encapsulation, and that will help people to relax, fall asleep faster. And then we have longer acting CBN on board. So that's not in that encapsulation. And that will help you stay asleep throughout the night. So fast onset of those beneficial low dose THC effects, which can be relaxing and calming, on board with those longer acting CBN effects to help you stay asleep throughout the night. Again, serving size is just 1 gummy. And what we're targeting here is that relaxation and that staying asleep. Important call out here, actually for both of the gummies we just discussed, both formulations are melatonin free, which is something that some people have sensitivities to or don't want to take for various reasons. And next slide, Marcel. Awesome. So this is just a quick summary of what I've already talked through. Just making a quick comparison between Stay Asleep Plus and Quality Sleep. So Stay Asleep Plus, these are for the patients who have trouble staying asleep, but they don't necessarily have trouble falling asleep at night, right? So it's like I'm up and down all night. That is what Stay Asleep is targeting. This is also a great option for people who are either sensitive to THC or do not or cannot take THC. Quality sleep is for the patient that has trouble relaxing or falling asleep and staying asleep. So it takes me forever to fall asleep at night, and then I'm up and down a bunch. Quality sleep is a great choice for patients who are not sensitive to THC or if it's not contraindicated, and they have that issue with both falling asleep and staying asleep. And next slide. Great. And then next, I'll just cover briefly our full spectrum soft gels as well as our full spectrum oil, which we'll get to in the next slide. There's a lot of overlap between the two. So our 60 milligram soft gels have that full spectrum effect that Marcel has been talking about, that entourage effect of all of the different compounds that are found in the hemp plant. What's really nice about the soft gels, they're super easy to take for patients who are used to taking a variety of supplements or kind of have their daily handful that they take. This is easy to incorporate in. Again, serving size is just one soft gel per day. And this is for kind of more generalized support with full spectrum, right? So not only might it help with generalized pain relief, but it might also help with supporting healthy joints, helping managing that everyday stress. We think about our full spectrum soft gels as like a daily support for daily wellness. And I think I just misspoke earlier when I was talking about pain relief, talking about it in the context of exercise-induced soreness and inflammation, everyday aches and pains. Great. And next slide. Great. And then we have finally our CBD Clinic 65 milligram full spectrum oil. So very similar to our soft gel, we have our full spectrum oil here. So we're getting that entourage effects, that general support. One thing that sets our full spectrum apart is our specialized patented genetics. So we have really specific genetics that we put into these products that we really stand behind. Again, the idea of supporting everyday wellness, supporting relaxation and recovery, and potentially maybe helping with sleep cycles as well. What's nice about the oil for people who are interested in this is there's a little bit more flexibility with dosing as you can titrate up because it's an oil in a dropper format. So serving size here is 1/2 milliliter, which translates to about 32.5 milligrams of CBD to 1 milligram of THC for the ratio. And you can start there, you can start even lower with the dropper and then work your way up until you find a therapeutic or effective dose for them. And next slide. Great. So in the 1 minute we have left, I will wrap up with our topicals. This is going to be a really fast overview, but if anyone is interested, we can certainly continue this conversation. So this is our level 5 pain relief stick here. So I have this one pulled up to talk about the camphor and menthol levels. So we have the highest amount of camphor and menthol that are allowed in OTC topical pain relief products. So we have 16% menthol and 11% camphor in this stick. We also have CBD and essential oils on board. All of our topicals have been dermatologist tested and deemed to be hypoallergenic through repeat insult patch testing. What's really nice about the stick is we consider it relatively mess-free, right? You take the stick, you open it up, you rub it on the affected area and go on about your day. So that's appealing to a lot of people if they don't like lotions and textures. And then next slide. I know we are at time, but this is just our topical lineup at a glance here. So again, we have those active ingredients of camphor and menthol that will be at varying levels depending on which product you're looking at. But our pain relief ointment and our level 5 stick have the highest amounts of menthol and camphor. So that's 16% menthol, 11% camphor. We have CBD as a supporting ingredient in all of our products. Those essential oils are on board, and everything, like I mentioned earlier, has been dermatologist tested. So we've got ointments, a massage oil, a stick, and I'm sorry, 2 ointments. And we are out of time. So thank you so much for sticking around and being here today.
And I'll open it up if there's anyone else that has questions. I'm happy to stick around. I know we're at the top of the hour. Thank you, Ivory. Are there any questions? Feel free to throw in the Q&A or yeah. Sounds like we're good. We're around. Um, Definitely, yes. Seeing a question of will we be able to get a copy of this? Yes, I believe this is recorded. Brittany is just responding yes, so we will pass this around. And then myself and Ivory are available if you have follow-up questions, if you want to see any of the articles that we talked about today, any of that, we're here. Awesome. Well, thank you all so much. Really appreciate your time, and have a good rest of the day.